This is Dr. Beth Miller, and I'm here with Dr. Barbara Marston. Today's date is August 1st, 2018, and we are in Atlanta, Georgia at the Centers for Disease Control and Prevention. I am interviewing Dr. Marston as part of the Oral History Project, The Early Years of AIDS, CDC's Response to a Historic Epidemic, the PEPFAR Years. We are here to discuss your experience during the early years of CDC's work on PEPFAR, the President's Emergency Plan for AIDS Relief. Dr. Marston, do I have your permission to interview you and to record this interview?
Yes.
Barbara, you've worked on the HIV/AIDS epidemic since early days as a medical student, resident, and then infectious diseases fellow, as an AIDS clinician in the earliest days of treatment, for CDC in Kenya, pioneering the scale-up of ARV therapy in Africa, and then providing scientific leadership at CDC headquarters, implementing PEPFAR programs in piloting and scaling up cotrimoxazole preventive therapy and other treatment for opportunistic infections and tuberculosis. You have also provided vision, scientific direction, leadership, and management of a number of the highest level CDC international public health programs, including the coordinated public health recovery activities in Haiti following the 2010 earthquake and ensuing cholera epidemic, the International Task Force emergency response to the Ebola epidemic, and the post-epidemic recovery capacity expansion in the West African countries of Sierra Leone, Liberia, and Guinea in 2014 to 16. We have a lot to talk about. Let's begin with your background. Would you tell me about where you grew up, your early family life, and then where you ended up going to college?
So I was born in Massachusetts, but we moved early to Pennsylvania outside of Philadelphia. And I grew up there. My dad worked for GE. They have a big office in Valley Forge. And then I went to Franklin and Marshall College, which is not too far from there. It's a liberal arts college in Lancaster, Pennsylvania.
Who or what influenced you to go to medical school? And where did you end up going to medical school?
So I'm not really sure. I wanted to be a doctor from very early years, so as long ago as I can remember. I got a little bit of taste of public health because I was 16 during the bicentennial and the Legionella outbreak in Philadelphia. So I had some awareness of people coming and investigating that outbreak. In fact, the F&M choice was because they had a reputation for being able to get people into medical school. And I ended up going to Temple. I didn't know how I was going to choose. Pennsylvania had a lot of medical schools. I wanted to go in Pennsylvania because it was less expensive and I'd have a better chance of getting in. And I didn't know how I would choose, but when I went to Temple, it definitely had the right feel, and I ended up going there.
What years was medical school? Were you seeing AIDS patients actually during your medical school experience?
Yeah, so that was 1982 to 86, and it was right during the time when there was growing awareness about HIV, but it was quite common for a patient to come in very ill, and what was it? Oh, and eventually it would work out that it was a gay man and that what he had was pneumocystis pneumonia, and that this was this immunodeficiency that had been described. It was a time when people were very uncomfortable talking about it, uncomfortable being on the same floor as the patients with HIV, and we had very limited treatment to offer at that time.
So you were seeing some gay patients with pneumocystis. Any other types of patients with other diseases that we came to understand were part of it?
That was honestly the main one. There were a few patients with Kaposi sarcoma, but pneumocystis presentation with pneumonia that eventually turned out to be HIV associated was by far the most common thing.
So then where did you do internship and residency, and what about AIDS during that experience?
So for residency, I went out to Portland, Oregon. I had an advisor at Temple who felt that if you didn't need to stay in the same place and you could go elsewhere, you should. He said medicine was different in different parts of the country. And I thought, well, I had no reason that I had to stay in Philadelphia, so I really looked on the West Coast and very much enjoyed the Portland program when I interviewed there. My clinical work there centered around HIV. Obviously, we did a range of inpatient training, but my outpatient clinic was in the HIV clinic there. So I had continued experience, and it was much of the same thing. That was now from 86 to 90, so we were evolving through having some treatment, for example, for pneumocystis, and beginning to have AZT available, but it was the time at which AZT would sort of make you live longer, but not necessarily better. We really didn't have effective antiretroviral therapy then.
And again, was it the same patient population? Was it mostly gay men with pneumocystis, or at that point were you seeing a broader array?
It was still dominated by gay men. Of course, there were people that had other risk factors. I particularly remember a patient that had acquired HIV through a blood transfusion. That was it was a very difficult scene. He presented to the emergency room actually with a rash from cotrimoxazole that he'd taken because he hadn't felt well, and he had thrush, so it was fairly obvious to me what might be going on. We couldn't get results immediately, but I had to at least raise the possibility both to him and his wife, and it turned out she was also infected. So that was one of the examples of tragic, it was very shortly before there were blood tests available. If he'd had his heart surgery delayed a few months, he probably would have had a safer blood supply.
Do you remember the experience of actually telling people that they had HIV and how you went about doing that in those early years?
Yeah, absolutely. I mean, most gay men by that time had lost multiple friends, and an understanding of the possibility of HIV was pretty common within that population. But it was still a very difficult thing to broach. And I remember talking to my program director, one of my outpatients, who wasn't in the HIV clinic. He was just there to be seen, but he also hadn't been feeling well, and he had thrush. And of course, I knew right away that was likely going to turn out to be an HIV diagnosis. And it happened so frequently that it was pretty taxing emotionally, even for me. And of course, I'm not the one that's sick, but to see that many people sick and dying was difficult. And we had a lot of challenging issues with, things like, should you put somebody on a ventilator? There were people with very strong feelings about whether that was appropriate for someone with HIV or not. And again, we were just in that kind of cusp where maybe somebody could get treated for pneumocystis and come off the ventilator. Most people didn't, and that's what was behind people's feelings about it not being appropriate. But it was the evolution of, at least having some treatments available for HIV.
Was there concern about infection control in terms of putting these patients on a ventilator?
Probably, yeah. I mean, people had the widest range of feelings about infection control. Some people were cavalier, and so they wouldn't even wear gloves to make the point that they were comfortable with people with HIV. And then there were people that were so frightened, again, they wouldn't go on the same floor as a patient with HIV. So a lot to try and navigate among especially healthcare providers, but also among family and friends.
Were these patients kept in private rooms, or do you remember an evolution of how these patients were cared for in inpatient setting?
It was a mix. I mean, our residency was at a combination of the University Hospital and the VA in Portland, with a few experiences at private hospitals. And so the VA was largely 4-bed wards at the time, although they opened a brand new VA in Portland during that time, and then there were mostly private rooms. So it wasn't really driven by the HIV. It was more so driven by what was available for everybody.
So this is Portland, Oregon?
Yes.
Yeah. Well, you mentioned the Legionnaires outbreak, but any other things that impacted you that you got interested in public health and decided to come to CDC?
So there were a few people in my residency that had experience doing public health or working at CDC. Tom Torek, in particular, had gone to that same training program and then done EIS. And so I got in touch with him and got some information about how to apply, and got pretty excited about it, which was a little bit of a shift for me. Even though I had wanted to do medicine, I envisioned myself more so as an emergency room doctor. That switched during medical school to internal medicine, and then this public health idea became pretty exciting to me. So I applied to EIS, and I remember very clearly when I got the call, it was from Patsy Bellamy, who had one of the strongest Southern accents that I can remember. And I wasn't necessarily able to understand her well when she spoke, but when she called with the news, she was obviously very excited, and so I assumed it was a positive response. And I was at the time, I was cross-country skiing on the back of Mount Hood, and this was in the days of, very, very early cell phones, but I carried one because I was on call for the residency, and the phone was, this big with an extra long antenna to go to Mount Hood. And there I was with the snow and the pine trees and thinking, what am I doing going back to Atlanta? But actually going to work for CDC was really pretty exciting.
So you got to CDC, and where was your EIS assignment, and what did you do during your EIS?
So I was a little complicated. It was the time that you've probably heard this about the match, was described to us as you would get matched with the highest position that ranked you. But in fact, there was a little bit of a global happiness algorithm. And so I had met Ron Waldman at the time, and I was struggling between whether I really wanted to focus on a kind of a research-oriented position or more of a program implementation situation. And he was very strongly in favor of the program implementation side and basically convinced me that I should at least consider the International Health Program Office. But in the end, I decided, no, I'd prefer some of the sort of bread and butter enteric diseases, respiratory diseases positions, and I ranked them the highest. I ended up matching with IHPO, and I know it was a little bit of the global happiness algorithm based on what people have told me since then, and also right before the match was announced, I was told I could switch to any position that I wanted that was still open. So I had the impression that they had done something a little bit unusual. And I have to say, how it evolved was I worked in the International Health Program Office for about 6 months, and then one of the people in the positions that I had more strongly desired had to leave EIS, and they let me switch to that position. So I am one of the very few people that did EIS in more than one position. And I think if somebody had offered me at the beginning, would you like to do 6 months of international work and then the rest of the time doing respiratory diseases with Rob Bryman, I would have said yes, absolutely. So I have to say it worked out pretty well. So
what'd you do for the international assignment?
So I did a couple of different projects. The first one was, so NHANES surveys were just starting in the U.S. then, or not starting. I guess the idea was starting that they would take NHANES ideas and maybe do those in international contexts. So there was going to be a survey like that done in Pakistan, and one of the questions was, have you been immunized against tetanus? And that turns out to be a very complex question because not just have you received the vaccine, it's have you received 2 in the last 2 years, and are you covered for? So there was a uncertainty about whether the answers to that question would be valid. And so we wanted to do some work understanding whether women could accurately report whether they'd been immunized against tetanus. So I was supposed to go and do a survey to understand that question. As it turned out, I was in Pakistan at the time just after Benazir Bhutto had been deposed, and new elections were coming, and so the plans for so there was going to be a trial of the survey that was delayed because of the election, and so I was supposed to do the trial survey and then compare to some clinic records that were supposed to be very high quality, but the records turned out to be maybe high quality for Pakistan, but extraordinarily difficult to understand, and then the survey wasn't done. So the project was a little bit underwhelming scientifically.
Did you go over to Pakistan then?
Yeah.
Was that your first international experience?
I would kind of say yes. I had set foot over the border of Mexico and in Canada and Niagara Falls, but I remember flying to Pakistan thinking, I'm not even sure this place exists.
How'd you do? How did it give you a real taste for international work, or?
It was a tricky situation. I went with somebody who was working on the survey, but he actually got off in Lahore, and I went on to Peshawar by myself. And so the person who I was working with there picked me up. I think he was very surprised at my age, which at the time was 30. So all of a sudden he had a fairly young American woman on his wing, which was it was a status symbol. So I was instantly a status symbol. During the course of the time there, because I treated him politely, I think he thought that I was in love with him, and he did sincerely ask me to marry him, so that it was a fairly uncomfortable working situation in that regard. And also, I expected to perform well scientifically, and like I said, there were some challenges that were beyond my control. So I wasn't sure how this was going to be perceived when I got back. The other thing that happened there was a major earthquake while I was there, and so I was I'd hired up a few women to do a sub-survey just to get the tetanus information from a group of people, and I was staying at one of their houses, and that's when the earthquake happened. So at the time, I was in a bedroom speaking with an older man in the family who had a broken hip, and the lights went out, and the walls were shaking, and I go, this must be an earthquake. And then I thought, well, you're supposed to go outside or to a doorway, but I didn't have any instructions in my mind for what you do if you're in a bedroom with a man with a broken hip. And luckily, it was blissfully brief, and by the time I even thought about what the possibilities were, the shaking had stopped, so I was able to stay there with him. And anyway, it was a big adventure. And when I got back, Ron Waldman and Michael Deming both kind of said, well, we were just really seeing if you could get across the airport. It wasn't, they didn't seem too frustrated by the quality of the science. We didn't learn that much about. I can tell you that women cannot accurately tell you if they're immunized against tetanus.
Oh my gosh, that sounds extremely eventful. Any strong memories from your EIS experience in the respiratory diseases branch?
So I ended up being the surveillance officer for Legionella. So that was kind of a full circle experience. That was exciting for me. And then working with Rob Breiman was also a great experience. We did some difficult work trying to understand the etiologies of pneumonia. And the work was in Ohio, but it was really an effort to understand, at a very detailed level, what are the etiologies of community-acquired pneumonia. And classic for Rob, we had a budget like this, and his idea was about like that, so we were always kind of scraping and stretching, but we got a lot of good work out of that. And then the other experience was Kevin DeCock was the country director in Cote d'Ivoire at the time, and he'd come back for a meeting, and somebody asked him, with what we perceive as all the HIV in Africa, are you seeing a lot of non-tuberculous mycobacteria? Are you seeing a lot of, Mycobacterium avium? And he said, no, we see a lot of different Mycobacterium ulcerans. And I ended up doing an outbreak investigation of ulcerans, and that meant that I got to meet Kevin and also see some of the work that was being done in Cote d'Ivoire at the time.
Mm-hmm. Did you learn something about what you enjoy most, or did you enjoy all of it?
I think that's my problem, right? So I've never really wanted to close any doors. As far as I'm concerned, if I could do a little bit of everything, that would be fine with me. And so even that, at the end of EIS, I actually was offered a job in the TB group, but there was a big part of me that was afraid to give up clinical work. And so I had been in touch with the people at Emory and talking about possibly joining their fellowship program. And in the end, that's what I decided to do after EIS, because I was afraid to give up clinical, not because I didn't enjoy the public health work, but so I did. Then I went on to do the infectious disease fellowship at Emory and did clinical work for the next, several years.
So this was, I guess, 1992, and your fellowship was at Emory in Atlanta. By this time, the AIDS epidemic is full-blown. There's 300,000 AIDS cases have been reported, and still over half of them have died. There's some AZT treatment. What did you experience regarding HIV/AIDS during your fellowship? And were you focusing on that group?
So rates of HIV in Atlanta were high, and the clinic. I worked in two big clinics, so at the Grady HIV clinic, and also at the clinic at the VA, and both were very large, a mixed population, and with respect to what we talked about before, so some gay men, some drug users, a few people with other risk factors, and it was very difficult work because we had very high rates of death. I think at the VA clinic during that time, we were getting about a death a week out of I'm not sure how big the population was then, maybe about a couple thousand patients in that clinic. But we did have things to offer. And it was during that time that we started having a little bit more to offer with respect to antiretroviral therapy. And I stayed on after the fellowship as a faculty member, and so it was, I think, 1995 when we really saw the first time when 3TC was available. So if you gave somebody AZT, maybe they died more slowly. But if you gave somebody AZT and 3TC, it actually got better. It didn't last very long because of resistance issues, but that was the first time we'd seen anybody get up out of their wheelchairs and go back to work or get out of bed or that kind of thing. So it was really exciting. And then we were involved in some early trials of triple therapy. So we had a few patients who were getting triple therapy, and the protease inhibitors is what we could use at that time. And so that was just, it was a sea change for the clinic. So after the 3TC experience, then we got triple therapy essentially the next year. So I'd say in 96. And so we got everybody on triple therapy, and the death rate went down to more like 2 a year instead of 50 a year. Just an amazing change.
What were, before 3TC was available, so during your fellowship, what were the types of illnesses you were seeing?
Well, the whole range. So lots of pneumocystis, plenty of capaces, plenty of CMV, quite a lot of CMV and retinitis.
CMV, retinitis?
Yes. A lot of tuberculosis, your friend or foe or whichever you want to say. A few very interesting things. We had a patient with Castleman's disease, which is maybe another manifestation of KSHV, the virus that causes capaces. Candida esophagitis, the whole works. And I guess you could either think, oh my gosh, all we have is AIDS patients, or you think, oh my gosh, we have, today it's Candida, and tomorrow it's CMV, and this day it's pneumococcus.
What were you treating them with? Do you remember some of the drugs that were available to you?
Well, AZT was obviously the main first one. Bactrim prophylaxis was common by then, so that was something we did for everybody with low CD4 cell counts. And I'm not sure I'll remember the exact year of introduction, but the years I really remember are 95 for 3TC, and 96 for the protease inhibitors, and 97 for efavirenz.
Okay.
So indinavir was the first protease inhibitor that we really had access to, and it was an incredibly effective set of drugs, but it was a handful of pills that, people had to set their alarms, and it was almost like a meal, the number of pills, and they had to be taken with a fatty food or an empty stomach, or it was a very complex regimen. But the patients were pretty willing to try and do that, and not everybody, but across the board, I would say people were able to manage taking it, and we saw tremendous improvements clinically in a lot of patients.
So so this is now you're at the VA, and attending at the VA. What was the monitoring you were using at that time as you were beginning to give out antiretroviral therapy?
Well, we had CD4 cell counts. I don't remember from when exactly, but I think it was 96 that viral loads became available, and we had them, sporadically available early on, and then they evolved into something that we did regularly. And then over the course of that time, we also started to get resistance information. We could get genotypes and phenotypes, later in the 90s. Excuse me.
What was it like for the patients at that time? What were some of the social and cultural factors that were going on as drugs are starting to be available?
Well, the VA population, there's a lot of concurrent sort of social complexities with that group. So a lot of poverty and a lot of issues with mental health. So quite a few of our patients were homeless or struggled to find a place to live. A relatively common phenomenon in Atlanta is that a bisexual man who isn't necessarily open with his female partner about the fact that he has male partners. So that was a kind of a common scenario to have somebody who had HIV but hadn't been able to disclose to his wife or female partner. Lots of, complex medical issues along with the HIV. So usually a problem list, as long as your arm. And a little bit of evolution over that time where, it had been that HIV was the number one, the big thing to no, HIV kind of went down the list, and some of these other issues became, much more important. I stayed on at that clinic, so I'm going to get memories mixed up. I think probably even after I came back from Kenya, I was going back to seeing patients there, but the rule was always if the patient had HIV, they came to the HIV clinic, regardless of what other medical problems they had. So, we would get somebody with a defibrillator, an implanted defibrillator, and they would be my primary patient because they had HIV, even if their HIV was fully suppressed, fully controlled, and yet, they had these cardiac problems. But that was a vestige of, in the early days, nobody felt comfortable with the patients with HIV except for our group.
Who were some of your colleagues at the VA and at your other clinic?
Well, so Dave Rimlin, probably the main one. So he's retired now, but was a giant in the HIV world and had the foresight to really collect a lot of. He got permission early on to collect standard information about all the clinics, all the patients in the clinic, and so we really had a good cohort in which we could do kind of descriptive studies of how we were doing with respect to viral suppression or the prevalence of hepatitis C or whatever other issues came up. And he and I kind of ran the clinic, but one of the bonuses about being this close to CDC, there are a lot of people who like to continue to do some clinical work. So back in those days, my situation was I wasn't attending in the clinic, but people would come over from CDC and spend maybe half a day a week. And I probably won't remember everybody that did it, but like John Kaplan, Ann Shookett, Mary Kam, lots of Peter Dropman, lots and lots of people. And we would have this, it was more so later, but reciprocal relationship. Like John Kaplan was my boss when I came back to CDC in the late 2000s, but he was essentially like my fellow in the clinic. So it was kind of an interesting thing. And that was always fun. That the CDC docs were pretty enthusiastic. The patients liked them a lot, and it meant that we were able to sort of extend our reach and manage way more patients than we otherwise would have been able to with the resources we had. That was a good.
Anything else you reflect on in your experience, clinical experience at that time?
My clinic, honestly, the HIV was really the dominant thing. Of course, I would do a little bit of other infectious disease and inpatient and occasionally with travel patients. And then as part of the fellowship, I did research, and I ended up doing my research back at CDC. So with Tom Shinnick and looking at tuberculosis, never really got any great scientific output out of that, but the basic idea was we were trying to understand what genes were turned on during active infection as opposed to during latent disease, and using a luminase detector protein to see which whether a gene was turned on or not during active infection. So throughout that whole time, I had pretty tight connections to CDC. I also had met and married Larry, and so he was at CDC. So I was, that was another way to stay in touch with CDC. And then, of course, the proximity between Emory or the VA and CDC, we had a lot of collaboration. So even though I had technically left CDC, I hadn't really left CDC, and people always like to assume, I've been here since 1990, but that's not even close to true. But I managed to maintain a relationship, with a lot of people at CDC through that time.
So then you and your family moved to Western Kenya. How did that all come about?
Well, Larry and I definitely wanted to go someplace. Western Kenya seemed like the perfect situation for him. So he had done malaria work, a little bit of work on foodborne disease, a little bit of work on HIV and TB, and basically the field station did all of those things. So it was a perfect situation for him. For me, our children were very young at that time. Before we moved, I'd been pregnant or nursing for the 4 years before we left. And I never saw Kisumu before we went. I just went sight unseen. But it was actually, it was an easy decision, and it was, it felt fine. I felt good about it. I had a rule that our younger daughter had to be 1 before we went, and we almost made that. She was about 2 weeks shy of her first birthday when we arrived. We arrived in Kenya on September 11th, 2001. Well, we arrived in Nairobi on the 10th, but we arrived in Kisumu on the 11th. And we left from Philadelphia because we stayed with my parents for a couple of weeks before we left. And so we drove up the New Jersey Turnpike to Newark, where we were flying from. And I don't know if you'd ever driven there, but about half of that drive, you could see the World Trade Towers in that time. And then we took off from Newark, and it was a cloudy day, but the trade towers were above the clouds. And so the very last thing that we saw of the United States was the top of the 2 World Trade Towers. And, I was on the plane with Emma and showing her, because she was not quite 3 at the time. And then, so we arrived in Nairobi, just spent the night in the hotel, went out to Kisumu. We didn't have phones. We didn't have internet. We had just arrived, so we had no information whatsoever. And our friend Kim Lindblade came to the door and said something's happened, and explained, what had happened. And at that point, we didn't know, would we stay in Kenya? What would happen? We didn't have cash. We had nothing. But we went and put our cards in the ATM and got cash out. And although there was absolutely no travel for a couple of months after that, eventually things kind of, normalized. And, we stayed. And I have to say that was, that time for our family and for my career, I think, was the best ever. So it got a little bit of a rocky start, but it turned out fine.
So this was in 2001, is that right? What was the atmosphere about HIV/AIDS in Kenya as you arrived?
So you might remember this. I can't remember exactly. It was 99 or 2000 maybe, that one of the big HIV conferences, they said, this is all well and good that we're making progress with treatment and with viral loads and things like that, but the world's HIV is not confined to the United States and Europe. It's primarily in Africa, and we should probably be doing something there. And that idea was just starting to take shape. I had actually planned to do malaria research when I went to Kenya. That was the arrangement we had made. But when we got there, that didn't seem like a good idea. The malaria research group was smaller than I had envisioned, and it would have put me too proximate to Larry as the field station director. And there I was, an HIV clinician, and there Kisumu was with an adult prevalence of 25%. So what made all the sense in the world was for me to do some work on HIV. And so Kevin DeCock was the country director at the time, and he and I discussed it, and really didn't take very long to make the decision that, no, this is what I should be doing. So this is prior to PEPFAR. And at the time, there was the Life Initiative, back at CDC, and there was some funding. It was primarily focused on testing and on prevention of mother-to-child transmission. But we had a small budget that we were allowed to start thinking about care and treatment. And it basically was enough to cover my salary and the salary of one person, and a colleague in Nairobi named Doris Masharia. And then we had $10,000 discretionary. And I think I told you before what I thought we should do with that. But what we decided to do is use it to buy cotrimoxazole. So there were several situations in which people were being identified as having HIV, and the whole point of testing, it was being promoted as, find out you're negative and stay negative. And there wasn't really much to say to somebody who turned out to be positive. But obviously in Kisumu, with a 25% prevalence, many of the people who were tested were positive. And so there was an enormous need to offer something. And even though antiretrovirals weren't in the cards at the time, it seemed like we should do something for those people. So we were able to set up some clinical services and essentially offer cotrimoxazole, which made a tremendous difference in the health of people. But it also let us get started kind of establishing clinical services. And then we could get antiretrovirals through a few channels. So I think.
Before we go into the treatment, can you tell us a little bit about, so 25% in Kisumu or in Nyanza province had one of the higher rates of HIV in Kenya. What were some of the factors that were driving this raging epidemic in Kenya at that time?
Well, the dominant ethnic group in Nyanza province is the Luo people, and polygamy is common there, and also there's quite a complex, set of beliefs that associates sex with outcomes of various things. So, for example, if you want to have good luck fishing, there's an understanding that you should have sex before you go out fishing. And I don't know, a lot of things like that. So if somebody's husband died, then there was a practice where the brother of the husband would inherit the wife, and that had sexual connotations. And so there were quite a few practices that led to having, people having interaction with multiple partners. And so the rate there was 25%, even though the national rate was more like 7%, but it was high in Kisumu.
And before you got into treatment, what were some of were there various prevention activities? You mentioned prevention of mother to child, so was antenatal screening and a treatment regimen used in a large way at that time when you got there?
So in those days, PMTCT was primarily just with single-dose nevirapine, and I wasn't super involved. I was involved to some extent. This all gets kind of complex, but when we wanted to try and extend what we could offer treatment-wise. So first of all, PMTCT was one example where you'd find somebody who was positive, and you say, well, okay, you can give nevirapine and reduce the risk that they would transmit HIV to their infant, but then what can you offer, the mother? So that was one source of patients. For this clinic, we started with the cotrimoxazole. But it also turned out to be one of the first ways we got any treatment availability at all, because there was a grant that was available from Columbia School of Public Health, and it was essentially to offer treatment to women who were identified in the context of PMTCT.
Okay.
And so I got involved in that. We wrote the grant and got funding so we could provide some treatment. So that was one source of antiretrovirals before PEPFAR got started.
And were those complete 3-drug regimens, or?
Yes. Yeah. I don't even know if I can remember. I think it would have been primarily stavudine, 3-TC, and nevirapine. That'd be the most common regimen then.
And were those complex regimens to take? How was retention in those early years of using 3
So people did well with it. I mean, obviously not every patient took every pill, but so the regimens were usually a couple of pills twice a day. There was a lot of concern, in the general world that, people wouldn't be able to take these drugs living in Africa. And I think that turned out to be a wrong assumption. I think people did at least as well taking the drugs in Africa as they did, any place else. It wasn't necessarily the very best regimen that was available in the world at the time, but it was the combination of manageable, affordable, relatively speaking. I mean, obviously these were very expensive treatments compared to usual therapies that are available in Africa, but stavudine was a couple dollars, a month, and so that was a drug that we could get and was available.
Were you required to use the U.S. approved drugs at that point?
It depended on the context. So, I mean, we did one activity in Nairobi where it was really an effort to evaluate whether you could give antiretroviral therapy in an African context. And that was in the Kibera slum in Nairobi, working with Doris, who I mentioned before. And for that one, we had to use U.S.-approved drugs. For the Columbia program, they provided the drugs, and some were and some weren't necessarily the U.S.-approved. We did end up, it's very complicated. So when Kenya was providing some drugs, those most of the time were Indian manufacturers.
Do you remember how you were monitoring the patients in those very early years? How often, and what laboratory availability you had?
So we had ability to do CD4 cell counts locally pretty early on in things. We
using fax counter?
I'm not sure. I can't remember exactly when we got fax count. We ended up with bunches and bunches of fax count machines, but I think even early on for the there was the capacity to do CD4 cell testing in Nairobi. And then, so for this program we were doing in Nairobi, that was this evaluation of whether you could effectively give antiretroviral in an African context. We did CD4 counts as part of the routine monitoring of the patients, and then separate from that, we sent blood back to the U.S. for viral load testing, not as a clinical monitoring, but as an evaluation of the effectiveness of the project. And
So this was this in the Kibera slum? Was it an observational study?
yeah, I mean, whether to call it a study or not was a big point of debate. So we had, I can picture, I'm not really sure who all was around the room, but it was Doris and me on one end of the phone, and then what sounded like a conference table full of people in Atlanta to try and negotiate whether this plan to provide antiretroviral therapy to people with HIV was a program or a study. Eventually, we got it described as a program with an evaluation component, which I think is just right. And so people gave a consent because they were getting blood taken for the viral load monitoring that wasn't going to be part of their own, monitoring. It was us trying to see if the program worked. But
now, what regimen was used for this one? Was this a similar regimen to what you were using in Kisumu, or a different approach?
I think it was either, I don't even remember, but I think probably stabudine 3-TC and nevirapine, or AZT 3-TC nevirapine.
But everyone was on the exact same regimen, is that right?
Essentially, yes. And that was one of the big features that made it different. So it was standardized regimens, and then reduced frequency of monitoring compared to what was regularly done in the U.S., particularly not so much with the CD4 cell counts, but with things like complete blood counts or blood chemistries and things like that. And my own experience was we did all that monitoring, but it rarely changed what we did with the patient. And even if there was something that we found with that monitoring, it would almost never be true that we would have stopped the drugs. Anyway, we felt better giving the drugs without the monitoring than not giving the drugs because we couldn't do the monitoring.
And you couldn't do the monitoring because it was too expensive or too time-consuming for the patient, or
it was felt to be not feasible from a scale-up standpoint. So in this focused effort, we could have, but given the numbers of people and the resources available in Africa, the thinking was that we would be better taking whatever limited resources there were, more so buying drugs and less so buying expensive laboratory monitoring. So it was really a sort of a resource distribution question. And
so would the monitoring have been more likely every 6 months, or do you have a...
Yes. Yeah. Whereas we might, even
in the U.S. it might have been every 3 months,
or even more frequent, especially at initiation. Yeah. And that was, it was a hard thing to sell, because one of the key things about any public health context is it's hardly ever comfortable to say, we'd like to give you this not quite as good, effort to control HIV as what we have in the U.S. But I felt pretty strongly at the time that what we did in the U.S. wasn't necessarily better. So yes, we did more frequent monitoring, and yes, we tailored the antiretrovirals to the individual patient, but I'm not sure it was a good idea. People would end up, well, I don't really like the pink pill, or I'd like a smaller pill, or I'd like one that's diamond shaped. You ended up making changes for silly reasons. And even from an individual perspective, if you had a standard approach, I didn't think we were giving them the B treatment. I felt like we were providing, A-level treatment. But
so now your colleague was Doris Macharia. She's a Kenyan. Did you need to go through any Kenyan institutional review boards, or their KEMRI? If you could describe a little bit about what was the Kenyan attitude towards this.
Well, the point we were just talking about was a big deal. So it was a multi-page protocol, but about 6 pages of it was, here's why there's really no need to do more frequent blood monitoring, and here's why it's okay to use standard regimens. And I would try and explain my perspective about that to our colleagues, and some people were totally fine with it, and some people were like, no, we want whatever you would do in the U.S. And then I think it was 2002 that WHO came out with their first guidelines for antiretroviral therapy. And WHO said, reduced frequency monitoring, standard regimens. And that made my life much easier because now instead of 6 pages of defense of this idea, I simply put, and in accordance with WHO's recommendations for standardized regimens and reduced frequency monitoring. And I think it was it was very telling about the impact or gravitas of a WHO recommendation in that context. People, once they saw that WHO had recommended it, and it wasn't just this American doctor trying to say that a lesser thing was okay for Kenya, that it became very easy from that standpoint. So.
Now, Uganda was doing a study looking at clinical monitoring versus more laboratory-based monitoring, but I don't remember the timing. Was that before or during your decision on this particular
It was
project?
about concurrent. I think Jana will tell you, but it was considered a study because there was randomization to the different arms, whereas
Right.
ours, everybody got the same treatment, but it was right about the same time. We had
Okay.
a lot of shared
So
experiences.
So the data weren't there yet, though, to confirm it.
Right.
Well, that must have been very exciting.
It was, and
How did it go in terms of the clinicians, the Kenyan clinicians, and whatever outpatient facilities were available in Kibera slum? How was healthcare delivery delivered in that setting?
this is a relatively small program. I don't remember exactly how many patients, but maybe 100 or a couple hundred. So we worked in one clinic in Kibera, and we basically had control and some resources to kind of up the level of care that was available. I would say, I don't know, for me, when I learned antiretrovirals, I learned AZT, and then maybe stavudine came in, I learned that, and then 3TC, like basically add one. These guys had to learn, the rack of them at once, but luckily we kept it a little bit limited about what they had to learn. But they were terrifically able to learn, and I think the quality of care that was provided was good. People were skeptical. Some patients had heard about antiretroviral therapy and were anxious to receive it. Some people were afraid of it. There were people especially some people that sold herbs in the area that they said were good for HIV, that felt that it would be helpful to them to spread some rumors that those drugs would be bad for you, because that way more people would come to them for the herbs. So we had to do some qualitative work and some, social behavioral communication kind of things to help people understand that we were sincere and that these were good treatments. But we got those viral load results back after we did the monitoring for a period of time, and 85% of the patients were suppressed. And we were talking about being emotional or not, but when that came back, against everybody's expectations, to have 85%, that was substantially higher than we were able to achieve in the very early days at the VA. And I think the difference was, the differences included, we didn't, in the early days of the VA, we had all these people that had been on AZT and then AZT 3TC and then triple therapy, whereas the group in Kenya started with triple therapy. So I think medically it's not surprising that we were able to achieve high suppression, but it dispelled basically people's concerns about adherence to therapy and whether it could be done, in this context. And it was pretty exciting to get those results back. Doris and I were both pretty.
So did that program continue when you stopped the implementation program, or what happened to that?
So it eventually evolved into a kind of a more regular treatment program, because scale up in general, started to happen around that time. So I had gotten the grant from Columbia for the work in Kisumu, and the main point there was they only supported treatment for the women who'd been identified while they were pregnant. But I basically made it a condition. I don't know what I was thinking, but when they came to visit, I said, we can't just treat pregnant women. There are so many people here who are sick. We need to use some of these resources for others. And they were generous about allowing those resources to overflow so that we could staff the clinic. They didn't give drugs for the other patients, but the doctor and the clinical officers were able to see the other patients as well. So that grant from Columbia supported not just the women who'd been identified in pregnancy, but was a critical part of the support for the rest of the clinic. And then we just started in little ways. A church or two would be willing to pay for drugs for somebody, or a study, or whatever. And we built up a small number of people around treatment. I think we started our first patients in very late 2002, and gradually built up a few in throughout 2003. And then PEPFAR was announced in 2003 and really got going at the end of 2003. And because we'd done some groundwork and there was great interest in seeing rapid results, the idea we had a clinic full of people that had been tested and counseled and were coming to care routinely, which, by the way, is weird in Africa. I mean, most people don't do that. Most people come when they're sick, and that's it. The only group that really gets regular follow-up care is infants getting immunization, and then maybe patients getting TB therapy. So this whole idea that you would go to a clinic for a chronic disease was basically a new paradigm, and it took some getting used to, but we did have a clinic full of people that were just ready for drugs. And so when PEPFAR started, we were able to kind of practically, snap our fingers and get a whole bunch of people on treatment, and that was the kind of result that people wanted to see. So we were well positioned to expand pretty quickly.
Did you scale up to several clinics at that point, or were you still based in a few?
So way more than several. So I essentially had two jobs. One, I was living in Kisumu and oversaw the treatment services in Nyanza province, which was a third of the HIV in the country was in that province, but then also nationally. But Doris was also working. So we both took the same approach in the areas where we were working, and essentially just went from clinic to clinic saying, would you like to start an HIV? This is once PEPFAR resources were available. And then we were in a situation where I could get as much money as I could spend, basically, to do this. And so you could go to a clinic and say, would you like to start an HIV clinic? And they would say, we would like to, but we don't have the resources and we don't know how. And I would say, that's okay. I have the resources and I know how. And working closely with Ministry of Health colleagues, we could just look at that clinic, figure out who needed to be trained, what equipment they needed, what supplies they needed. And then generally the pattern would be we'd start the clinic, enroll people, start them on cotrimoxazole. If they'd been on cotrimoxazole for a couple of months, then they could start triple therapy. So I think the pattern now is sort of test and start treatment right away. But at the time, we were still in this mode of worrying that people wouldn't adhere to therapy. And so we would kind of get people on cotrimoxazole for a couple of months. And if they managed that, then they would start the triple therapy. And
where were these clinics? So were these primary care clinics? Were they district hospital level clinics?
Yeah, I think there were, I want to say 12 districts in Nyanza province. I should be able to name them. But so we started by going to all the district hospitals and then all the health centers. We gave a little bit of extra focus to an area where CDC was doing research studies. So in Asembo Bay and basically Siaya district, the whole organizational structure in Kenya has changed now, but it was province and districts, and I feel that while you can't offer services like that to individuals who participate in research studies, that it's perfectly ethical to prioritize those communities that contribute to research studies for receipt of services. So no individual has to participate in research or not, but because the community has been participating in research that we were sponsoring as CDC, we kind of went there first, and it made sense anyway because those were the highest rates of HIV. So the district hospitals in Siaya and Bondo, and then
was it
the other ones.
Was it hard for patients to get there? How did a patient get to the district hospital for the treatment? Was there transport issues?
There definitely were, and especially, for individuals that felt too stigmatized, then the transport became a bigger deal because they wouldn't necessarily feel comfortable going to an HIV clinic in the village where they lived because almost everybody had a cousin that worked in the lab or, that would see them. So I think the transport issues would get in the way of adherence when patients would try to do things like go to a different district hospital to get their treatment.
How bad was the stigma of HIV at that time in Kenya?
I don't think you can really give a specific answer to that. It varied by individuals. So some patients were very willing to just show up and come, and they would also be willing to speak publicly about their HIV, and I think that helped a lot of other patients. But there were people that just would not, including, people that worked for CDC that we would pretty well assume had HIV, but we couldn't manage to convince to get tested, or took a lot of, quiet work to get somebody to be willing to be tested. We lost some people at CDC because they, even though the treatment was available, we couldn't necessarily convince people to get tested and into treatment.
Was it difficult for women or adolescent women in terms of marriageability and so on? What was the feeling about that?
That's an interesting one. I mean, that was also variable. To be honest, a fairly common thing was we would test a woman, find that she was positive, tell the husband, and the husband would be like, I don't want to know that. And that would be it. So maybe still marriageable, but now this risk of transmission within the marriage. Others would disown the person when they knew. So it was a hard thing. And I think the hardest part in some ways was that a woman couldn't agree to have a test without the agreement of her husband. So if we were wanting to offer testing or treatment to a woman, you had to work with how to get the agreement of the spouse, because the husband was the decision maker. And eventually we solved that by switching to an opt-out. So that we said, we're going to do testing unless you say otherwise. And in that way, she could blame it on us. She said, the clinic did this. I couldn't make the decision to tell them no without you. So I've been tested. Stigma was, it was huge, but we were offering something that was so new and so needed that we didn't really have to worry about it except for that individual, meaning that we had plenty of patients that were coming at any given day. We were busy, and I remember the people back in PEPFAR headquarters were like, wow, if the national prevalence is 7%, you're going to have to test 100 people to get 7. So how to meet these, treatment goals? How are you going to test, that? You don't have to test that many people. I mean, it's all good if we test people, but all you have to do is hang up a sign that says we offer HIV services and sick people will come and you'll offer the services. And so we were basically picking the low-hanging fruit at that time, and didn't have to worry, too much. You'd worry about that individual and say, really, we'd like you to come, but if we couldn't get that person to come right then, we had plenty of other people that needed to get the services.
That must have been so exciting. What was the evolution of the community's experience of AIDS? So you get there and there's not much treatment going on. There must have been a lot of funerals. What was the atmosphere like in that way?
I mean, funerals were the common activity. Most people went to a funeral every single weekend. The thriving business when I got to Kisumu was coffin making, and there were coffin makers on every corner. And I think I said when we talked about this before, when we hired staff for studies, we had to overhire because we knew we were going to have a certain amount of attrition because of illness and death in the study staff. And the thinking about antiretroviral therapy ranged from one extreme to another. And some people that were aware about it in the world thought, we should have this in Kenya. Some people were very afraid of it. As people started to witness individuals who got the treatment kind of getting better, it became much more accepted. I think the first group to really feel the impact, of course, the individuals who got treatment, but then the healthcare workers. So the healthcare workers, you go to the provincial hospital at the time. Within the hospital, 85 to 90% of the hospitalized patients had HIV, and the death rate was enormously high. And so the clinicians were kind of like, what am I doing? If every patient dies, why am I a doctor? Why am I a clinical officer? And for me, it was the second chance to see the impact of antiretroviral therapy, because we went from, a whole group of people that were sick and there was nothing to offer to instant triple therapy. And people even with the cotrimoxazole, people got dramatically better, but with the triple therapy, they got dramatically better. And, the clinicians would call and, Barb, Mr. So-and-so's back. He's gained weight. He's much better. And that happened over and over again. And I think for the morale for the healthcare workers was the first thing, that came up. But then almost everybody had family members with HIV. And if you stretched it out far enough, almost everybody had a family member with HIV who'd gotten treatment and gotten better. And so it didn't take very long before people really appreciated and understood. And you could, I don't know, you could test. I always like to test with the taxi drivers, do you know about HIV? Do you know about treatment? And early on, no. But over the time there, they became very aware. They always had a family member who'd been treated. And or they would say, oh, yes, we used to take people to funerals all the time. Now there are no more funerals. Yeah. It was a big and palpable change in sort of the rate of death, and at every level. So in individuals that got better, and in the clinic, and then in the community, you could see the impact.
So now you were working for CDC, you were, I guess, reporting to Kevin DeCock in Nairobi, and then back in Atlanta, part of the PEPFAR staff in a distant way, or?
Yeah, I mean, it was actually kind of complicated.
Multiple.
Technically, I was working for the VA.
Oh, okay.
We had an interagency agreement
Okay.
that the VA
Yeah.
paid the salary, so CDC would hire me, and then I think once PEPFAR kind of came in I was under Kevin initially, but as PEPFAR kind of expanded, essentially under Ted Ellerbrock's team.
Yeah. Can you comment a little bit about CDC's role in all of this? You mentioned it by the side, but can you sort of dissect a little bit about what CDC was doing there and how CDC worked in country and what advantage it was to being a part of CDC while you were there?
Well, it was mixed, honestly. So, our big thing, of course, is to work closely with ministries of health, and that was certainly the case in Nyanza province. And I very sincerely tried to make everything we did be a part of the Ministry of Health's efforts. And even the early clinic, where it was supported by the Columbia resources, it wasn't, my clinic, and it wasn't a Columbia clinic. It was the provincial hospital clinic, and with these resources. And then I think I mentioned a little bit this woman, Lena Nyabiagi, that I worked with in Nyanza province, and she was very interested in supporting the HIV work, so much so that she volunteered during her time off to come, and initially she did some work on the TB program, but we got to know each other, and she eventually became the antiretroviral treatment coordinator for Nyanza province, and we were quite a team. So, of course, I had all the dollars, and she had the title, and we would go together to a clinic and kind of work out, and then I was able to say, yeah, we can support this and this, and she then could say to the clinic, well, I've identified these people that will get treated. We will bring you cots, and we will bring you, and so the Ministry of Health clinic, they were all ministry clinics that we worked, not 100%, but almost all ministry clinics, and at the time, I mentioned PEPFAR really wanted to see these rapid results. And so if another partner, like a funded NGO or whatever, could see, oh, these Ministry of Health clinics were doing very well, they would like to kind of jump in and be the partner. And I go, no, I'm already the partner. But they would say, well, we can't see, it doesn't say, NGO X on the sign here. It says Ministry of Health. I go, that's right. That's how we work. But so it's a little bit of a double-edged sword. I think Bill Fahey, makes a point that as long as you do the work right, the appreciation will follow. And I'm afraid I don't 100% agree with him on that. I mean, I feel like we lost a little bit in terms of being so careful to credit the Ministry of Health, which I personally believe in completely. I think the problem in that equation is the people who want to ask, well, what have you done? And I go, well, okay, I was behind that, but it's easy for people to say, well, maybe it was just the Ministry of Health doing it on their own. And it wasn't. I mean, I was working very hard to make this a reality. And early on, it was no longer true, but early on, I was the one with the knowledge. And so I could do the training and figuring out how, at this point, the clinicians in Nyanza province have surpassed me by log scales, with respect to the numbers of patients that they've seen. But early, it was helpful to have substantial clinical experience. And anyway, so you can you can overdo it, is what I'm trying to say with respect to crediting the ministry. We, as PEPFAR scaled up, we worked closely with USAID, and it was complicated and not always good. I had a wonderful colleague on the USAID side who was doing the care and treatment stuff, and he and I worked together on some great. We had some difficult stuff and then some great stuff. Like one of the difficult things was early they had some partners that simply weren't performing, and he was like, Barb, you have to give them credit or a break. They're not used to being judged on what they get done. And I was like, well, what are they judged on? And, it had been until that time kind of ability to spend money, which that's fine, but why don't we at least anyway, over time, that's one of the great things PEPFAR has done, I think, is shifted the focus of our development work to outcomes rather than just, spending money. But that was the culture, at the time. But John and I also, we, where do you get your drugs for PEPFAR? That was a big issue. And eventually there was this whole supply chain management project. But prior to that, how we did it in Kenya was to get the drugs through something called the Mission for Essential Drugs and Supplies. And it's a fantastic organization that supplied drugs to the mission hospitals. And I remember John and I, we needed to get
These were the faith-based, the mission hospitals?
Yeah, exactly. But we needed a contract signed, and MEDS, the Mission for Essential Drugs and Supplies, the people who were on the board were all these archbishops. And I don't quite know what happened because it was a USAID contract. But anyway, we got to the point where we needed the contract signed. We needed 6 signatures from archbishops in a period of about 24 hours. And John and I went off on the great bishop hunt. I got 3, he got 3, and mine were all in Western Kenya. Luckily, 2 of mine were Anglican because it turns out to be a lot easier to find a bishop if they're married because you can find their wife and then they know where the bishop is. And, so a CDC driver and me driving all over, hello, well, have you seen him? Do you know where's his wife? And eventually we got the contract signed. Anyway, and it was fun working with John on that and sort of seeing the national scale up. So we, not really officially, but eventually kind of took different regions and different partners and were able to make things go pretty fast in Kenya. I'm not sure it was the best approach. I honestly think, if you go a little more slowly and get it a little more standardized, that's probably better in some ways. But I think for PEPFAR, having a country that was going very fast, like Kenya, was helpful in securing additional resources. So, we ended up with a bit of a mishmash with people with different programs and doing it in different ways because there was already such a broad range of NGO partners in Kenya. And other countries like Tanzania, I think, did it much more. Everybody's going to do it the same way. And I think if you drew a graph, Kenya would go up faster, but Tanzania, over a certain amount of time, would get to the same point because that kind of standardized approach maybe would work out better in the long run. But we were able to get a lot done fast, and I think that was helpful for returns for the whole PEPFAR program.
And do you think it controlled the epidemic more quickly by virtue of the rapid scale up?
Sure. I don't even know
Yeah.
exactly what the situation is in Kenya right now. I think they're at 1 million and some on therapy, which is crazy. Because for me, I think I told you this before too, but that early clinic we had in Kisumu, we had 300 and something people on treatment before PEPFAR started, and we'd gotten a call. Elizabeth Marham got a call from somebody from NIH saying, "We'd like to help you start a clinic." And she says, "Well, I think we already have some people on treatment. Let me call Barb and find out." And she called me, and she's on the phone to both of them. She goes, "Yeah, they have 300 and some people on treatment." And the NIH person was like, "Oh my gosh, that's some huge number." And the idea that 300 people is a lot of people, is ludicrous at this point, given the numbers. And even, I felt like we were going fast, but when I left Kenya, we were at about 65,000. And that's peanuts, compared to what has been achieved since that time. But it was, the slope of the curve was steep. And it was, even that was enough to make that palpable difference really across the country in terms of funeral frequency.
Any other reflections on the experience in Kenya that come to mind?
Well, like I said, I mean, it's definitely the best job I've ever had. I mean, the idea that there's something you're very comfortable doing and you have the resources to do it, that's a pretty amazing situation to be in. It was also, I mean, Kenya is a beautiful country, and we had help in the house, so even though we were working hard, it was very gratifying work, and we didn't have to spend time, cleaning the bathrooms and whatever, and so,
How did your family do? How did the girls do?
There's a little tiny school in Kisumu. Things have all changed since the post-election violence in 2007, 2008, but there was a beautiful little school with, trees with weaver birds, and they both went there and learned everything we could have, and we expected we'd have to come back sooner for Emma to start school, but she was doing fine and learned to read and everything. So it was a good situation for them. And then, I'd be in the hospital in the daytime, and then at night go down to the shores of Lake Victoria, and there would be hippos and gin and tonics, and travel to the Masai Mara and see cheetahs and leopards and whatever. So it was a pretty spectacular opportunity for our family, I think.
Well, you've done so many things, but I thought maybe we would conclude by talking a little bit about your experience as the lead of the affected countries team in the International Task Force Emergency Response to the Ebola epidemic in West Africa, where CDC played quite a role. Can you tell us a little bit about what your role was in that position, and briefly describe?
Well, I always smile when people ask me that, because I was down in Haiti, and Mark Anderson called and said, "Can you do a rotation in the EOC?" And I just said yes without asking a question.
The EOC is the Emergency Operations Center.
And so I got there and I said, "Okay, what's my job?" And they go, "Well, you're going to lead the heavily affected countries team on the International Task Force." And I go, "Okay, who's that?" And they go, "That's your first problem." So essentially what had happened was the viral special pathogens people had deployed experts to the field for the initial part of the response, but of course people couldn't stay there forever, and they now needed plans for who was going to replace them. So essentially my initial job was find people that would be willing to go out to each of these countries to coordinate CDC's efforts in the response. And this is where 20 years of time at CDC really comes in handy, because, for example, I called Jono. I said, "Jono, would you like to do it?" I may have talked to my husband to see if he wanted to take a lead role. I called Kevin, everybody I knew that had the appropriate experience to maybe coordinate a team. And I'm
you
not.
Want to say a line or two about the epidemic, just in a few sentences, what was going on?
Well, so it started at the end of 2013, but it wasn't recognized until well into 2014. And basically, Ebola hadn't happened in West Africa before. It had been present for quite some time before the diagnosis was made. And CDC had been involved in the initial response, but hadn't necessarily been involved in the kind of what turned out to be a resurgence. We hadn't been invited back, and it was getting worse and worse and worse, and the world was kind of watching, and nobody really, I think, in general, people didn't take it as seriously as it needed to be taken. And so it got worse and worse and worse, and eventually CDC stepped up and took a big role in the response, and the three countries declared disasters, and the USAID came in with resources, and CDC assisted with that whole response. But it was...
and it ended up being about 11,000
deaths.
cases.
No, 28,000 cases and 11,000 deaths, an absolutely enormous epidemic. And, our contributions to the response early on were just kind of figuring out what to do and predicting what was going to happen and tracking the epidemiology. And then I think we really shined or shone, or whatever the word is, toward the end of the response, when what you really have to do is find every last patient and make sure that every contact has been identified and that those contacts have been monitored. We had some some very important, inputs into seeing to the end of the epidemic in all three countries. But it was at the time, it was the biggest response that CDC had ever done, and big by a landslide. And so finding the people to do the response and dealing with issues like making sure that we had plans for medical evacuation if somebody needed that, and then just coordinating the efforts in a situation where nobody had really done this before, figuring out what to do and how to communicate that back to to the agency head and up to the White House. And that was really just a coordination job from my perspective. So find the people that would go and keep in touch with them as teams, maybe pass down some advice about what to do, not so much from me, but from Ebola experts and others, and then gather the information from them to feed up, here. So I went for 30 days, but I ended up staying for 2 and something years. And then the work of assisting the countries with recovery of their public health capacity after the epidemic was something that was very familiar to me based on experience in Haiti. And so I ended up having that role until we were able to essentially work ourselves out of a job, and those countries ended up being handled more like all the countries are getting supported.
So can you comment on CDC's role here in terms of what CDC brought to the table, to the experience?
For Ebola, I mean, yeah, again, I think, obviously laboratory, our standard stuff, so surveillance, not without its challenges. Surveillance is hard in a situation like that, but we did a lot of work to try and track the epidemic, offer a lot of laboratory testing, but I think the sort of field epi was the thing that we brought that was the most important. And then after the epidemic, helping to stand up their surveillance systems more generally, helping to build laboratory capacity, making sure that there were people trained in epidemiology. So all three countries have field epidemiology training programs now. And, tremendous progress. We wrote a paper about it that sort of explained that even though that kind of capacity building, generally speaking, takes years, you can do it faster under some circumstances, and this was one. And maybe a couple of the reasons are that one of the things you need to make public health progress is you have to have stakeholders believe that it's important, and not just the people in the Ministry of Health, but the president of the country or whatever. Well, you want a president to understand the importance of public health, and Ebola epidemic will do that. And so we had everybody on board. We had developed relationships, very close relationships with our counterparts in the ministries of health, and so we were, I think, very well positioned to support that kind of rapid expansion of surveillance and laboratory capacity. So it was a pretty exciting time. Prior to this epidemic, CDC's presence in West Africa had been pretty limited, not zero. I mean, there was the field station in Cote d'Ivoire, and we had activities in Senegal and Nigeria, but these three countries in particular didn't have a ton of CDC presence, and so we do now. I think that's good.
Parallels have been drawn between the response to the Ebola epidemic and AIDS. Do you want to comment on that at all? Did you draw on some of your experience in addressing AIDS in the early years?
Sure. I think the Ebola felt to me like the HIV epidemic on fast forward. There was a lot of the same things, like couldn't really be, and then it is, and then we need to do something, right? But a little bit slow to it, and then an aggressive response, very stigmatizing for the people that had Ebola. I think maybe the closest parallels beyond that kind of fast forward thing, we did some work trying to test. So we learned, especially in the course of this epidemic, that Ebola can persist in the semen of male survivors and maybe in some other places in survivors. But that meant that one of the things that CDC did was help set up some testing programs for survivors. And so you're asking somebody who'd survived Ebola to come in, provide a semen sample, to be tested for Ebola, and then to give back the results. And that whole setting was very similar to HIV testing and counseling. To be honest, it wasn't something I was super involved in, but you could definitely see the parallels. And we ended up tapping into some people with really strong experience in the HIV counseling and testing realm to do that kind of testing and counseling for the Ebola survivors. But I think, in terms of its devastation and its ability to highlight the stark disparities between the well-resourced world and the under-resourced world. It felt, similar in many ways to me. I think people are amazed or surprised to find out, let's go train all the people in Senegal. They've had one case, of Ebola. Well, we can train them, but by the way, they don't have gloves. So you're going to have to start with getting some gloves there too, and people just can't. I think it was hard for people to really picture what the circumstances were, but these were very poor countries, and the impact of Ebola was pretty stunning.
Well, thank you very much. Any parting reflections on, well, this has been terrific. Thank you so much.
Thank you.